receptor alpha or anti-TSLP be given. 40 from his exacerbation on inhaler therapy required repeated oral corticosteroid therapy, 3 exacerbation, hospitalization in the ward. Now, this is the chest X-ray, typical hyperinflated lung fields. Total count 11,200, eosinophil 38, ECG echo within normal limit. Now, what to that is the track 1 therapy, and discharge after 3 days. Again after 1.5 months with an IC of 358 and eosinophil of. So this is severe obstructive disease with significant bronchodilatation reversibility. So what to do? Should we use a device? The answer is that you may try. Whether you do CT, yes. After doing all those things, you excluded all those factors and coined it as a case of severe asthma. Yes, which one to choose? The patient was started mepolizumab, and after receiving the second shot, patient was much requiring any oral corticosteroid now. So any specific biomarkers to evaluate the patient is responding or not? Probably eosinophil may be used, but it is not. End of the day, it is the clinical symptom and spirometry indicators, and most importantly, whether patient is having exacerbation free or not. How long do we continue? No clear-cut guideline mentioning that how long it should be continued. Some recommended at least for 3 years, but again I am reiterating, will have recurrence of symptoms or not. How to de-escalate? Same thing. Whether you should de-escalate the frequency that once a month to once in 3 months or not that. Case to another patient, 40 from asthma for around 6 years, repeated again, one leading to hospitalization. She was on medium dose ICS LAVA. In spite of that, she is having symptom, spirometry, severe obstructive disease. How should we proceed? Which ICS to be tried? So I will not go into this question. Patient is on maximum dose of ICS LAVA, also LAMA glycopyrrolate, still not control symptoms suggestive of severe asthma. So how to proceed with the hypereosinophilia? Count is 2142, pheno 28 billion, serum Ig 798, IgE and IgG against fumigator done and came out to be negative. Now, what are the biologicals which can be given in this case? Again, if you ask me, it will be the mepolizumab. This is the last case, a 50-year-old male bank worker with a severe asthma on maximum dose of in a still having multiple episodes of exacerbation with chronic rhinosinusitis, polyposis, with LAMA plus LAMA. Look at the Ig, it is 63,400. So diagnosis severe asthma with severe eosinophilia, and treatment with the biologicals based on the endotyping has been done. This is a case with such a high Ig, we will prescribe omalizumab. Based on the endotyping, mepolizumab, reslizumab and benralizumab also can be given. So how long mepolizumab should be given? Answer is still we are unaware of that fact. Long-term retention of mepolizumab, there are studies, but the conclusion is that it is not still known. So by wrapping up, if you ask me about the biologicals, there is no clear-cut use, but it has to be used in severe asthmatic population. Number 2, Thank you very much.
Thank you for your nice deliberation. Any questions trying it. But one thing I must say in this August gathering regarding this eosinophilia, you have rightly pointed out that eosinophilia cannot be the predictor of treatment. And another point I want to add that in a country like India, actually it is written in textbooks of medicine that in countries or in people where there is more helminthiasis as well as filariasis, we must treat the eosinophilia with one dose of antihelminthic as well as heterogen, one course of heterogen, before giving much importance to the eosinophil count. So the clinical criteria is more important here for the for choosing a treatment for a disease like bronchial asthma. Thank you, sir.
Thank you, sir. Thank you.
So the next speaker is Dr. Karthik Nagaraju from Chennai. He will talk about addressing complex allergies, evolving strategies in combination therapies.
Thank you, sir. Good morning. Good morning, everyone. Thank you so much for the invitation. I'll be talking about how to address complex allergies by using combination therapies. And by combination therapies, we mean that how to use allergen immunotherapy along with biologicals. I will be restricting this particular presentation to only allergen immunotherapy plus biological therapy. So we know that allergen immunotherapy is the only disease-modifying therapy with a proven benefit for Ig-mediated allergies, especially allergic rhinitis, asthma, certain types of food allergies also. And in this particular situation, there is a gradual increment of the allergen dose, whereby we are trying to stimulate and switch the Th2 type of inflammation towards the Th1 type of inflammation. And we are also trying to address both the regulatory T cells and increase the regulatory B cell also to reduce IgE production. The aim of treatment will be to provide long-term relief of symptoms, improve the quality of life, and to reduce reactions to subsequent exposures over a period of time. And a mechanism of allergen immunotherapy is well known that it addresses multiple aspects of the immune system, wherein if you see, after starting allergen immunotherapy, the first thing to reduce would be your mast cells and your basophils, and your activity would be reduced to a month. And this is sustained over time with reduction in their activity over many years. It takes a while for the local and systemic effects of the protective antibodies and for the regulatory T cells and B cells to increase over time, and it takes a while for sublingual immunotherapy and for subcutaneous immunotherapy to improve the IgG4 levels and also to achieve what is called as sustained unresponsiveness. What we mean by sustained unresponsiveness is increase in the regulatory B cells and the T cells also. So we know that allergen immunotherapy is able to address a wide variety of the allergen spectrum, especially allergic rhinitis, allergic asthma, venom hypersensitivity, food allergies, pet allergies, and even atopic dermatitis also. And there is no benefit with regards to or urticaria, angioedema, or latex allergies. So there are several challenges which comes with managing allergen immunotherapy patients. Something that we tend to see regularly are your polysensitized or polyallergic patients. In such situations, we don't know which target to choose for immunotherapy, or we have already chosen a wrong target for treatment. And there is also using multiple antigens, the efficacy of each allergen is also reduced. Therefore, that becomes a challenge. In situations like severe asthma or severe allergic diseases where the FEV1 is less than 70% or the patient has an uncontrolled asthma, they are based on multiple randomized controlled trials not included in the study, therefore not much data is available, and these patients are associated with severe allergic reactions during therapy, and it is generally avoided in such cases. If there is coexisting food allergies or if there is coexisting multiple food allergies also, there is increased incidence of severe reactions when the patients are on allergen immunotherapy over time. And if there is atopic dermatitis, there is both IgE and non-IgE mediated reaction. So allergen immunotherapy addresses only the IgE mediated, therefore we might not get better responses with allergen immunotherapy monotherapy alone. And if there is presence of comorbid conditions such as your autoimmune disease, to treat them with a better allergen immunotherapy options. In the presence of anaphylaxis where there is high risk of severe systemic reactions, or if there are unusual allergens like native pollens which are from India, for the proper standardized extracts available or not much definitive data of treatment is not available, in such situations it becomes difficult to choose allergen also, especially in some cases like and what are the different biologicals available. So in biologicals, they are nothing but humanized proteins, antibodies, which target certain antibodies and cytokines and cells in the immune system, and based on these target they are able to reduce the response of these cytokines and antibodies over time and bring about their protective benefit. So there are multiple biologics which are already approved for different conditions. This is the list of all the antibodies like omalizumab, dupilumab. We just heard everything for asthma, but for food also omalizumab is not recommended. For atopic dermatitis, dupilumab is a recommended. The other JAK inhibitors also being recommended for atopic dermatitis. Chronic sinusitis and nasal polyps also, omalizumab and dupilumab are also recommended options. These biologic agents are targeting cytokines. Therapy targets innate immune system. So when we are having two different disease modifying targeted therapies, can we combine these two together for modifying your treatment? And if so, how do we choose which biological to use? So we'll take a case scenario here. One of the important cases which we can think about would be a 21-year-old male with a college student who has severe persistent allergic rhinitis and uncontrolled bronchial asthma, currently on step 4 GINA. He is having frequent exacerbations requiring admissions and oral corticosteroid use. There is a history of shellfish allergy also with episodes of anaphylaxis or even urticaria angioedema. He is currently avoiding all shellfish. He has exposure to a pet cat which is since last 2 years. His lung function is showing obstruction, moderate to severe obstruction with bronchodilator reversibility and elevated FeNO levels. The peripheral blood picture is showing elevated eosinophils and an elevated total IgE counts. So we have checked for his technique and it is appropriate, and adherence is also appropriate to this therapy. So then we evaluate for atopic because there is a strong history of atopy in this clinical likelihood. So we did specific aspergillus fumigator specific IgE which was negative, and house dust mite was positive in these patients. Also prawn was also positive, and also incidentally detected pollen to cynodon and also to cat for which he is exposed. So this is a typical scenario of a T2 high asthma which sir had already previously explained about, where there is a strong house dust mite sensitization and there is a possible tropomyosin cross-reactive antigen positivity. So we are now in the world of component resolved diagnosis or molecular allergy, where like how we are having molecules for biologicals which we are targeting and treating. Similarly, in allergen immunotherapy also in allergies, we have biological targets or molecular allergies which are able to diagnose and efficiently prognosticate patients with severe allergic diseases. So we continue, the cat is removed, inhaled corticosteroid is increased because FeNO was elevated, and also the patient was on step 4. LAMA was added sequentially, but over 3 months he still continued to have symptoms. His FeNO reduced partially to 44 parts per billion. Though we did a component resolved diagnosis, which is the most advanced version of allergy testing, to identify whether he is a candidate for allergen immunotherapy. So we did what is DERPI1 and DERPI2, which are major antigens. They are strongly positive. DERPI10 is a cross-reactive antigen which explains the shellfish related reactions in him. and FELD-D1 for cat and SIN-D1 for pollen are also positive. So he is multiple allergen sensitized, so polyallergic patient. So he is planned for allergen immunotherapy, but after a lot of counseling, house dust mite subcutaneous immunotherapy was planned for him because of cost constraints, and he is unsure about adherence also because he is a college student. We don't know how adherent on daily therapy he will be able to take. But he is worried about systemic reactions, he is worried about asthma exacerbations. So what next can we do? Is this a scenario where we can try biological therapies? Biological therapies, and what target should we use based on IgE levels, IL-5 or IL-4A? This patient is a target for all the different versions of biologicals which were discussed earlier, but he also has dust mite positivity. So can we directly start dust mite immunotherapy alone? So we have, now what is the role of combining oral allergen immunotherapy with anti-IgE omalizumab? So here the IgE binds to circulating IgE levels and reduces the density of IgE affinity receptors. By downregulating the specific IgE and mast cells and basophils, it is expected to improve the hospitalizations, reduce exacerbations in asthma and related adverse events, and prevent new sensitizations also. This is a paper from Bozek et al. Where they found that with a patient who is on combination of subcutaneous immunotherapy and omalizumab, the number of admissions with exacerbation of asthma was significantly lower compared to omalizumab or immunotherapy alone over a period of 1 year. There was also a significant reduction in the budesonide inhaled corticosteroid dose also over 1 year, and there was also a significant improvement in the asthma symptom score after 1 year period of treatment with a combination therapy more than individual therapies alone. So there is multiple evidence available since 2002 till 2022. It is effective in both pollen allergic patients with severe allergies. Multiple polysensitized dog, cat and dust mite allergic patients have had a reduced number of visits required to a hospital for exacerbations. Even in severe asthma in both pediatric and in adult age group, they have been able to show that by combining the allergen immunotherapy with omalizumab, they were able to reduce the asthma severity and improve, even lung function has also shown an improvement. I'll take a few minutes extra, sir. Is that okay? Yes, sir. So, okay. So, fine. So, omalizumab is also used if you are able to produce better benefit with allergen immunotherapy, and we also know that the specific IgE levels drop initially and then improve. So can we give a targeted treatment in patients where we are trying to give accelerated regimens such as cluster immunotherapy or in rush immunotherapy? So this is a case report where they tried the case series where they tried in omalizumab for allergic rhinitis patients where rush immunotherapy was given. So if you see rush immunotherapy, it is nothing but where we give rapidly increase the allergen doses within a 1 to 2 day period and reach the maintenance dose, and then we start maintenance therapy immediately. And this is recommended in venom therapy. This is recommended in severe allergic rhinitis patients who are at risk and those who are coming from far away also. So there they found that pre-treatment with omalizumab for up to 9 weeks before starting rush immunotherapy was associated with with a significant reduction in the acute reactions during immunotherapy, and also reduction in the severity scores over a period of 3 months period. And if you see the number of side effects, if you think that combining two therapies may have a higher incidence of reaction, actually allergen immunotherapy plus omalizumab actually had a significant reduction in the incidence of severe reactions. So based on this, the international consensus for guidelines on allergen immunotherapy for allergic rhinitis mentions that anti-IgE can be useful as a supplement or as a pre-medication prior to rush or cluster immunotherapy protocols by producing long-term induction of tolerance and increased efficacy and safety. So this has also been studied in pediatric asthma.
Please wind up.
I'll just need 2 minutes, sir. Is that okay? Okay. Okay, fine. So in this patient where there is pediatric asthma was studied, omalizumab was found to improve the maintenance dose in allergen immunotherapy patients. So for those who are having severe asthma who are contraindications currently as per IACI guidelines not to undergo house dust mite immunotherapy, by adding omalizumab followed by allergen immunotherapy may be a good option to increase the outcomes with allergen immunotherapy. So they've also tried to study for dupilumab with immunotherapy for atopic dermatitis, which significantly improved the eczema severity scores also. Dupilumab has also been tried with sublingual immunotherapy for house dust mite, and they also found that there was a significant reduction in the asthma quality of life questionnaires. So tezepelumab, which sir mentioned, has also been tried with cat allergen immunotherapy in the West, and they found that combination therapy was much more significant compared to cat immunotherapy alone. We know that recently omalizumab is now recommended for multiple food allergies, Ig-mediated severe food allergies, and it has also been found that the more number of food allergens are positive or more food allergies are there, omalizumab has had a better outcome in such situations. And in the presence of severe asthma with underlying food allergy, omalizumab has had a better outcome, and it is now recommended by FDA for children more than 1 year of age. So what is the role of combining oral immunotherapy with biologicals? It has also been shown that by combining oral immunotherapy, they are able to achieve for multiple foods and for even cow's milk or hen's egg or for peanut allergy, they were able to achieve desensitization earlier. So there is much more increased safety with a higher efficacy with a combined oral immunotherapy and omalizumab in these patients. So a small word about passive immunotherapy, they gave targeted IgG4 to the birch pollen, and they found that a single dose was producing significant reduction in the symptoms over a 3-month period. So allergen immunotherapy plus biologicals is to improve the allergen immunotherapy effectiveness, reduce adverse reactions, act as a steroid sparing effect, and also extend the indications to severe asthma or uncontrolled allergic diseases also. So which are the patients I would like to choose? These are the current studies which have been available, like severe asthma with FEV1 less than 70 are good candidates. Cluster immunotherapy patients who are planned for rush immunotherapy also. Multiple food allergies or severe atopic dermatitis also are good candidates. You have to understand that there is a wide variety in the dosages and the duration of drug used. So we don't know how long to use treatment, like sir said, but we need reliable biomarkers. But there is enough evidence for omalizumab at least to be added, which is currently available in our country, which can be added to allergen immunotherapy for the severe allergy patients. So in conclusion, there are targeted therapies available, but combination may be considered in complex scenarios, and the combination enhances the early response and desensitization rates. We need joint decision making prior to initiating both omalizumab plus allergen immunotherapy. Thank you.
Thank you, sir, for your exhaustive lecture. Any question from the audience? If there will be no question, I have got a small query. So long you have talked your talk is very exhaustive, and you have said everything how to natural allergens such as food and all those things. But what about the human used allergens such as vehicular exhausts, chemical irritants? How to treat with biologicals, because they won't produce any. So how do you?
So in this situation, if there is an indication for like they have T2 high and T2 low asthma, the same mechanism will be useful for that patient. You don't tend to give them with allergen immunotherapy in situations where there is exacerbated asthma.
Specific, you have set specific drug for food allergens.
Yeah, so for like this, you are asking for if it is if there are any specific drug. Right now, omalizumab, especially with the presence of asthma, for such patients, yes.
Thank you, sir. Thank you. So far, we have learned about the about the treatment regarding the acceleration of immune response. Now we are here for the measurement of this rate of acceleration. Now the next topic is from biomarkers to treatment plans, and the speaker is Dr. Kaushik Saha.
ওই এপি আইকন অ্যালারকন দেখো অ্যালারকন So my previous speaker এটা না 2025 এটা তো হলো, এটাই তো আগেরটা হলো, দেখো অ্যালার্কন 2025 লেখা আছে। Previous speaker, from the speech we all know that what is allergen immunotherapy all about, and who are the candidates, ideal candidates. Yes. And who are ideal candidates for immunotherapy? Now, regarding how to decide who are and when the allergy immunotherapy will help them to reduce the symptoms, and how to decide when to stop this allergen immunotherapy by doing simple some serum testing or biomarkers. So we all know now in the era of precision medicines, biomarkers help to decide regarding personalized treatment. So we are now moving from an epidemiological aspect of treatment to the precision medicine, that the treatment protocol should be individualized. So I will already, my previous speaker given an overview of allergen immunotherapy. Now what are the biomarkers available, and how they link to respiratory allergy, and how we choose the ideal candidates with help of biomarkers, how to assess the response by biomarkers, and when to stop allergen immunotherapy, whether biomarkers helpful or not. So this is allergen immunotherapy, that we are reducing the systemic response to the specific allergens by giving some therapy. So there are different modes of therapy available. We are usually from long ago the subcutaneous route is available. Now the sublingual route is also available in India, and there are other routes are also available. So these are the different that already been discussed. So these are the different types of biomarkers that are linked to respiratory allergens. There are 7 domains of biomarkers are there. So in the domain 1 there is different IgE, there is total IgE, specific IgE are there. In the domain 2 that the IgE4 subclasses are there. In the domain 3 there is the inhibitory activity of IgE that we all do, that is IgE-Fab and IgBF, to know the response for allergen immunotherapy. Domain 4 is the basophil activation, that is there is CD63, CD203 are there. And the cytokines, chemokines is the domain 5. There are different interleukins and different chemokines like MRC1, eotaxin are there. Then the domain 6, there is a cellular biomarker, that is the regulatory cells, T regulatory and B regulatory cells. And lastly is the domain 7, that is mainly the in vivo biomarker, that is the skin prick testing, the nasal allergy testing, these are there. So this is a graphical representation of different types of biomarkers and how they stimulate. There are cellular, humoral biomarkers, metabolic biomarkers. These are the different types of biomarkers. So how they will help? So our main candidates are the patient having allergy. Being a respiratory physician, my main concern is allergic rhinitis and asthma. So by doing skin prick testing or serum specific IgE, usually we confirm there is a sensitization to some allergens in our patient. And there is also newer test, CRD is also available, by which we can distinguish whether they are primary sensitizer from cross-reactive allergens or there is any other allergens are there. We can choose that allergen which is the most important allergen by doing CRD. But the most important part is we will reduce the symptoms of the patient. That is our main concern, that we will give symptomatic relief to the patient by giving this therapy. So we will improve the quality of pharmacotherapy is enough for our allergic rhinitis or immunotherapy addiction. So pharmacotherapy should be the first choice. Then if the patient is not relieved, his quality of life is not improving by doing pharmacotherapy, we will go for allergen immunotherapy. But when you decide to go for immunotherapy, you should ask the patient that the immunotherapy will go for minimum of 3 years. So patient should be adhered to that. that's long-term therapy, you should counsel the patient prior to starting immunotherapy. So before starting any therapy, you should counsel the patient well. So how long this therapy will go on. Now, what are the key biomarkers available to select our patient? So these are the different types of biomarkers usually we do. The most important is the specific Ig by total Ig ratio. How it will help? So a higher ratio, that is more than 16.2%, predicts better immunotherapy efficacy, particularly in the monosensitized patient. So this is very important because immunotherapy is a challenge for polysensitization. So if the patient is monosensitized, then the patient responds very well to the immunotherapy. Like there are example of some threshold. If the threshold is more than 9.5 KUA per liter for house dust mite, or for bark pollen, if it is more than 9.7, the patient is you can predict the patient will be benefited by giving immunotherapy. The total Ig helpful more in the pediatric cohorts, and it in some studies it showed that the total Ig level more than equal to 965 Ku per liter may outperform the ratio of specific Ig by total Ig in some pediatric population. These are some functional biomarkers. I am coming later on because it is more helpful in assessing the symptoms or assessing the response against the immunotherapy. These are the cellular markers that also we do after starting immunotherapy, but to see the regulatory cells, amount of regulatory cells, T regulatory and B regulatory cells. These are the newer tools like component resolved diagnostic. It identifies sensitization to major allergens like BED V1 and excluding polysensitized patients less likely to respond. So you should keep in mind that if the patient is polysensitized, they will not respond very well to immunotherapy. So immunotherapy is very helpful for monosensitized patient. There are other tools are available like omics migration integration is there, and also some AI driven models are coming, because now the main focus of in precision medicine is artificial intelligence. It is growing very fast in medicine field also. So what are the biomarkers available to us for assessing early response? First, the most important is the basophil activation test or BAT. So if we do the test, we see that there is reduced CD63 or CD203 expression post AIT, and it indicates a early desensitization and predicts a clinical improvement. It is useful within weeks to months to start AIT to confirm treatment engagement. So you will continue the treatment because it is showing response. Secondly, we also do Ig blocking factors like IgFab or IgBF. So it is a serum-based marker that inhibits the allergen Ig binding. Rising levels correlate with symptom improvement. Usually we do it through the flow cytometry or ELISA. Third one, most important, is the IgG4 levels. If there is rising allergen-specific IgG4 within 3 to 6 months, it also confirms a immune tolerance induction and good compliance. These are the cutoff values for that. Now, how we will decide by doing biomarkers a sustained efficacy? So whether the efficacy will be sustained or not. So for that, the T regulatory and B regulatory cells is very important. If there is increased IL-10, T regulatory and B regulatory, it correlate with long-term tolerance. So patient will be better if we continue that immunotherapy. Also there are some eosinophilic markers also available like nasal eosinophils or eotaxin are there. If it is reduced, then we can predict that there is suppression of the T2 inflammation. Our main goal is to suppress Th2 inflammation. But if there is persistent in eosinophilia, it may signal a suboptimal response and necessitating adjuvant therapies. Lastly, the cytokine profiling like decreased IL-4, IL-5 and IL-13 in nasal fluid or serum indicates Th2 pathway suppression. Now there are some in vivo markers also we usually do, because in all patients or in all setup we can't do biomarkers. So you can do a nasal or conjunctival provocation test. If there is reduced symptom severity post allergen, it challenges confirms efficacy and consider the gold standard but resources intensive. And secondly is the skin prick test reactivity. If there is reduced wheal size, also predicts sustained tolerance, but it usually it correlates poor with the symptom score. So biomarkers are always better than the clinical validation. So this is in gist what are the biomarkers we usually do to assess the response against the allergen immunotherapy. Now, how to decide the treatment duration? Whether biomarkers will help in deciding the treatment duration also. So usually the standard protocol is for 3 years, supported by robust evidence of sustained clinical immunological benefits. There are also some subgroups are there who have a high Th2 response or endotypes. They may require longer courses of 5 to 7 years. So if there is early IgG4 rise, it permits a shorter course of therapy for 2 years in selected group of patients. Then if there is the Ig-Fab stability is there, then it also predicts a relapse-free outcome and supporting discontinuation at 3 years. But if there is a rebound of Th2 cytokine, it signals for an extended therapy. So this group of patients, if there is IL-4 or IL-13 level rise during treatment, then those group of patients may require a extended period of therapy. So this is a nutshell. What are the biomarkers usually we do? So pre-EIT screening we usually do the serum specific Ig by total Ig ratio and the basophil activation test to exclude the non-responders. Apply allergic specific Ig threshold, like one example for HDM is more than 9.5 KUA per liter. Secondly, early monitoring by the Ig-Fab assay and the IgG4 trends within 3 to 6 months to confirm is there is immune modulation, the Th2 response is decreasing. Thirdly, long-term decision you can use this nasal provocation test or T regulatory activity to guide discontinuation at 3 years. So by integrating these biomarkers, clinician can optimize the EIT efficacy and reduce cost by 30%. So in this table, in a short, for diagnosis we do specific Ig, BAT or FeNO to identify the sensitization and the endotypes. For EIT planning, we do the specific Ig threshold and IgG4, personalize the allergen selection. For monitoring, we do the basophil activation test and the T regulatory cell. And before stopping, we usually do the Ig-Fab, see the Ig-Fab stability, so that we can stop the therapy at 3 years if tolerance is confirmed. So this is all about all the biomarkers we usually do when we are planning to start immunotherapy and planning when immunotherapy should be stopped. So this is all about biomarkers in immunotherapy. No, if there is presence of tuberculosis, you have to treat the tuberculosis well before starting or planning any immunotherapy. Okay, so the tuberculosis is very well. Then when the tuberculosis
Some cases of tuberculosis, actually we have to use inhalation. In rare cases, we have to use oral steroids in low doses. See, is it possible here? I want to know, is there any protocol or anything like that, or just omit, go for the previous treatment?
No, regarding
These things, whether they are more effective or less injurious than steroids.
now biologics asthma and in other autoimmune diseases, the concept is the biologicals usually we use in asthma Well, so if the patient needs he must you can go for biology suppress
Then it's better than oral steroids.
now, yes, obviously, because in the list,
Yeah.
GINA guideline, GINA usually not to my opinion on most of the patient will on
Yeah.
who need for to control.
Thank you, sir. Thank you. So with this, I conclude the session here. So next.
We will be felicitating Kaushik Shah. Dr. Or. Sir, please wait.
Now we'll have Dr. Chando oration. Professor Shunimal Chando, an internationally later he worked in the of allergy under history. Professor Chando was the founder of the Medical Society and was also elected president of the International Association for Epidemiology and presided over the MD from University. He's in our organization. I request may I request to felicitate Dr. Shamazdar.
was not that this type of empty. We had lot of especially actually in finding reasons we have so as this is, I think my slide not visible. Please give me that my slides. So as today it is about therapy, and I shall share my perspective. But lecture I should pay respect and research. To meet a philosopher. That also I learned from Professor Sunirmal Chando, and Dr. Shoibal Moitro is a student of Professor Sunirmal Chandra, and I myself feel proud that Professor Shoibal Moitro also consider me as his student. So I want to dedicate this particular lecture to my mentor, Professor Shoibal Moitro sir, who is again a student of Dr. Sunirmal Chando. And this was again, I want to acknowledge all my mentors in the field of allergology, starting from Professor P.K. Vedantan sir, Dr. Arijit Das, and Dr. Shoibal Moitro. And of course, I want to pay my respect to Professor Shantanu Kumar Tripathi, who was my guide during my DM training, and he had given me the topic, that is allergy and immunotherapy, as my thesis. So let's start straight with this case. Often we face in our day-to-day practice this 21-year-old female who had presented to us with running nose, sneezing, itchy throat, eye, nose itching for last 2 years. Last 6 months, she had quality of life almost near zero, sleep disturbances, very much irritable. There were 7 episodes of suffering by cough, sore throat, nasal blockage, and for that she took lots of antibiotics, as we can see here, starting from azithromycin, coamoxiclav, doxycycline. So, and most of the cases, those antibiotic injection was over the counter. When we took the family history, we found the mother and grandfather, they had history of atopic disease. And last 3 years, there is a change in residence, and now she is residing in a damp house. Most importantly, when we talk about symptoms that triggered by during the late night and that leads to awakening from sleep. Now, when we go back to the past medical history, what we found, there is a similar type of history when she was 8 years old, suffering from breathlessness, wheeze, chronic cough for 4 years. She was on MDI, metered dose inhaler, don't know what type of metered dose inhaler, which drug she was consuming. And for last 10 years, there is a history of frequent attack of cough and cold. And again with cough and cold, that associated with frequent consumption of antibiotic. Now we know that when we talk about different allergy symptoms, they triggered antibiotic consumption, unfortunately. Why? Because sometimes mimic the allergic infective disorder. So that's why again 50% received antibiotics, and when patient there is an increased risk of filling at least 2 antibiotic prescriptions per year compared to non-allergic asthma. And most importantly, again, this was a pediatric study which had shown 38% of pediatric antibiotic prescription was inappropriate. Today we have one cricket match against Pakistan. We may have some rivalry against Pakistan, but there is a common similarity also. We can see this study from Pakistan where it was found inappropriate use of antibiotics was seen in 78% cases where no antibiotics were indicated. So I think the situation is same here. And why we are talking about antibiotics, I want to focus this important dangerous liaison between bacteria, antibiotic therapy and allergic disease. So here we can see what are the microbes that present in healthy lung and what are the microbes that present in the asthmatic lung. And this change in microbial composition that had been one of the very key factor by which the Th2 phenotype developed inside us. So again in this diagram we can see the importance of gut-lung axis, and when we talk about gut-lung axis we need to acknowledge those friends who are present inside our gut producing some favorable ligands, favorable metabolites like short chain fatty acids. But if we destroy them, if we get some enemy bacteria that will produce certain different types of metabolites, maybe branch chain amino acids, which will stimulate our immune system, start from innate happen ultimately, there will be a shift from Th1 to Th2. So that is, we can see the microbiome diversity that actually changed in our allergic lungs. So again, this is again a picture where we can see how the lung microbial dysbiosis happened in asthmatic patient. So this is a population-based study which had shown the antibiotic overuse might be associated with increased risk of allergy-related disease. And why we are talking about allergic disease? If we capture those patients early and if we start something called as allergen immunotherapy, which can reduce the risk of exacerbations and lower respiratory tract infection in both seasonal and perennial allergic asthma. So the vicious cycle of allergic episodes leading to antibiotic consumption, and again that antibiotic consumptions lead to disruption in our gut microbiota, which can dampen or hamper the lung microbiota to the gut-lung axis, and that gut-lung axis change again provoke us to have more Th2 phenotypes, more Th2 inflammatory cytokines, interleukin 4, interleukin 5, 13. So this vicious cycle can be tackled if we use allergen immunotherapy at right time. So now, what is allergen immunotherapy? This is nothing but a repeated administration of specific allergens to patients with Ig-mediated condition for the purpose of providing protection against the allergic symptoms and inflammatory reactions that are associated with natural exposure of allergens. So this is a sort of hyposensitization or allergen-specific desensitization. The allergen immunotherapy is the only option which can modulate the patient immune response amongst all therapeutics we have to treat our asthma patients or allergic rhinitis patient. So they target the T lymphocytes, they activate the Treg cells, so that will suppress the Th2 mediated immune responses. So ultimately what happens, it will attenuate or modify the patient's symptoms upon exposure to the relevant antigen. This picture we all know the basis of type 1 hypersensitivity reaction. I want to highlight the area where the antigen presenting cell and T cells, T naive cells make a handshake, and after that handshake there will be lot of pro-inflammatory cytokines like interleukin 4, 5 and 13 that make the T cells to 0 cells to become Th2 cells, and then that Th2 cell and B cell will have some another handshake that causes the shift in the normal Ig responses. So instead of IgG, there will be lots of IgE will come inside our circulation. So class switching happened, and those Ig will go and find the Fc epsilon receptor on top of mast cell, and they will sit on top of mast cell, and that is we know as sensitization. Now again a re-exposure of allergen that will be classed by those IgE which is sitting on top of mast cell, and that will degranulate the mast cell and histamine will come into the picture and we will have symptoms. So in whole this game can be targeted by allergen immunotherapy. So if we have allergen immunotherapy, they will increase the Treg cell activity, we will have more interleukin 10, and that will counteract those Th2 mediated inflammatory or pro-inflammatory cytokines, and on top of that there will be a shift from Th2 to Th1 response, and we will get interferon gamma that will again give us some protection against allergic reaction. And as we talked about the class switching that happened by that second handshake between we'll have again the class switch, correct those class switching deviation, and we'll again get back IgG and IgA. Especially IgA is important when we talk about the oral immunotherapy. And we'll discuss about some initial rise in specific Ig followed by decline after starting the allergen immunotherapy. So this slide summarizes how allergen immunotherapy works. It acts on T lymphocytes as we had described. It acts on B lymphocytes and produce more blocking antibodies like IgG and IgA. It acts on dendritic cells. The dendritic cells are those antigen presenting cells which starts that handshake with T naive cells. So from the very beginning we'll get some blockade and we'll get more interleukin 10 that will protect us against allergy. From monocyte also we'll get interleukin 10, and when we talk about mast cell and eosinophil, in there the pro-inflammatory cytokinemia, that also can be regulated. So what will happen finally? We'll have better quality of life, better symptoms and symptoms control, and the need or requirement of the medication will be decreased. Also, some objective evidence of reduced skin prick test reactivity will be there. So in this slide we can see the initial there will be a rise in IgE followed by the decline of Ig. Some echo is coming, I am sorry for that. Anything from there? Okay. Can I have some pointer, because this is not working. And after that, another important blocking antibody we need to focus, that is IgG4 and IgA. They will have a gradual rise, and there will be initial rise in interleukin 10, and that will reach its peak by 3 months, before 3 months, and it will maintain that plateau phase. And this is practical, that is where we should use allergen immunotherapy. These are the indications, starting from allergic rhinoconjunctivitis to allergen-induced asthma to atopic dermatitis, Hymenoptera or venom hypersensitivity, though it is not available that much in our part of the country. And sometimes we may consider for atopic dermatitis in addition to different other first line therapies, because atopic dermatitis, it is not having the class 1 indication. There are certain questions, queries, whether we can use it in children. Yes, it is safe, it is well tolerated, and it should be considered along with pharmacotherapy and allergen avoidance for allergic rhinitis, asthma and insect allergy. If it is 5 years or more, we should start it immediately, and if it is 3 years or more, in some subset, we need to think of initiating this too. Pregnancy, again, allergen immunotherapy can be continued. Whether we should start allergen immunotherapy, especially the building up period, that is not recommended till date. But if the patient already achieved the maintenance dose, we can continue the allergen immunotherapy in pregnancy. So the take-home message for pregnancy should be, we should not initiate allergen immunotherapy in pregnancy, but if the pregnant mother is on maintenance, these are the list of contraindication. Especially we should not use it in uncontrolled asthma, where lung function is markedly compromised, unstable angina, recent myocardial infarction, patient is having significant arrhythmia, uncontrolled hypertension, failure of a major organ system. There we should not use, especially the cause why I am not using in these cases, because there is one adverse allergen immunotherapy. It is there. In this group of patients, difficult to manage, and that is why prevent. Similarly, when the patient is on beta blockers, it is not like that beta blocker is going to have some adverse interaction with allergen immunotherapy. But the thing is that if a patient is on beta blocker and patient is having anaphylaxis, it is little difficult to manage. We know there not only adrenaline works, on top of adrenaline we need to sometimes use glucagon. So that is why the considerations for those cases like SE inhibitors, again we know that SE inhibitors can cause, so that may again adverse effect of allergy therapy. So these are contraindication, not absolute contraindication. We need to do the case-based risk versus benefit analysis. These are the simple rule when it works. Number one, we should select patient properly. Number two, the antigen should be selected properly, and their composition and the administration route should be proper. Generally, from our teachers that young allergic patients suffering those patients, and those are compliant with allergen immunotherapy, they will have the maximum beneficial effect. When does not work, if we select patient poorly, that means patient is suffering from long-term disease, and many times we treat our patient who are suffering from non-allergic disease. So then it will not work. Wrong antigen selection, poor quality of antigen, and having some other comorbidities, there it will not work. So we have building up phase, and we will have some maintenance phase. There are certain types or schedules already this about maintenance phase. Generally we give it in an interval of 2 to 4 weeks between injection, and the most important message is the duration of allergen immunotherapy. It is 3 to 5 years. So we can see here the initial the vial 1 maybe for 3 to 4 months sometimes we use, then vial 2 and vial 3. After vial 4 we need to give the maintenance phase, which is 1 to 2 doses per month, and during the building up phase we sometimes give 3 days interval or sometimes give 7 days interval. So these are the two important phases, like build up phase and maintenance phase, 1 to 2 injections per week, and generally it takes 3 to 6 months to reach the maintenance phase. In some subset we wait for 1 year also, and maintenance phase means the injections between injection there should be a 2 to 4 weeks interval. Ultimately our goal is to reach that 6 to 20 microgram of major allergen concentration, and that to be given for around 3 years. These are the guidelines taken from our guideline. We can see starting from 1:5,000 to 1:500 to 1:50, and how we can achieve the maintenance dose. These are the card we use in our treatment center. We can see here generally we use 7 days gap. We start from 1:50,000. We not take much risk, and then 1:5,000, and then 1:500, and then we reach 1:50. I think this is a paper. This is easily available in net. You can download this. The dosing, how we should prescribe allergen immunotherapy, along with Professor Shoibal Moitra. We had written this review article, and again we can see here starting from 1:1000, 1:100, this should be given in a weekly basis. Sometimes we may consider 3 days. When we reach the maintenance dose, the patient can tolerate those maintenance dose, then we can fix that maintenance dose maybe at 1:1 or 1:10 in 0.5 ml, and we can give it 2 weeks or 4 weeks interval. After that also we need to reach the maximum tolerated dose for getting the optimum response from allergen immunotherapy. This was one of our review article we had written published in IJO, where we try to dissect some evidences of allergen immunotherapy in ocular allergy, and again the mechanism is same, how we make ourselves, our allergic patient, to not to have reactions against those not noxious agents, like house dust mite is a non-noxious agent. In that non-noxious agent, we are having some reaction. So by this mechanism, how we can shift the Th2 mediated reaction to Th1 mediated reaction, and having certain cytokines, we make ourselves immune resistance. So this was again one review article we had written with Professor Shoibal Moitro. These are few important points again. What are the important factors which increase the clinical efficacy of allergen immunotherapy? We had discussed early age and initiation of allergen immunotherapy in the course of the disease. So short duration of the disease, they will have the highest level of efficacy. And if we have less involvement of the lower airways, good compliance and adherence with 3 to 5 years of allergen immunotherapy, and a high cumulative dose of allergen immunotherapy if we can reach, as we had shown in our one of our slide, that will always associated with better efficacy. So when to discontinue allergen immunotherapy? So we had a session on biomarker, but importantly, we don't have any that specific biomarker which can tell us now you have to stop, skid or slit. The dictum is it is not wise to continue allergen immunotherapy after 5 years, and discontinuing venom immunotherapy can be done with severity of the initial reaction and reactions during therapy and the duration of treatment. Again, we must say in this part of the country we don't have that immunotherapy. What are the adverse drug? It is but they are not bothersome. Some large local reactions may happen like in this picture, but they are not necessarily predictive of future systemic allergic reactions. And if there is some persistent large local reaction, we may consider this following, like cool compress, like pre-medication with antihistamine. We can tell our patient, please take one antihistamine, and then after 30 minutes you take AIT. Temporary dose adjustment sometimes required if those reactions are large. So the thing is that when we talk about SLIT, the sublingual immunotherapy, which is very much, you know, that local reactions are there, not very severe systemic reactions are reported, so safety factors are high. Maybe some itching of the mouth, swelling of the buccal mucosa, some abdominal pain may happen, and rarely hives will be there. So while using SLIT, generally the epinephrine is not required. We need to be aware about anaphylaxis. Again, that is very rare complication of SCIT, and I think in our allergen immunotherapy, allergy asthma treatment center for last 12 years, I were there. So 1 lakh patients had been given for SCIT, and we and need to be prepared, because anaphylaxis is something we need to act promptly. So it is always good to have before SCIT. So where to administer allergen immunotherapy? Ideally we should use the physician's office. It is not always possible to give allergen immunotherapy in an allergist center, but we can contact some local physicians also. They can, in their office, we can give allergen immunotherapy. Only thing is that the physician should know how to tackle anaphylaxis. And when we talk about evidences, there are systematic review and meta-analysis that had been published now, and that is why all the guidelines starting from ARIA to GINA, they are recommending allergen immunotherapy. This was one paper very recently we had done, the systematic review meta-analysis, where the SCIT versus SLIT whether there is any changes in the efficacy and safety. We don't found any changes between efficacy and safety when we talk about SCIT and SLIT. But the problem with SLIT is that those papers that had been taken in this study, they were standardized one. But we know that SLIT in our country is not at all in all the standardization of the extra is a interesting to highlight, because this patient with inhalational corticosteroid suffered from diminution of vision, and he had stopped taking that inhalational corticosteroid for diminution of vision, and actually he was suffering from ICS induced glaucoma. So what we did, we started allergen immunotherapy. He only can tolerate the Montelukast, and now the patient is very good after 4 years of allergen immunotherapy. He also not required much the Montelukast. So this was the benefit of allergen immunotherapy, because it can modify diseases. So this was published in November in Journal of Indian Medical Association. It is our study. Generally, this is one part of my thesis activity, the real world evidence of allergen immunotherapy on medication score and medicine usage pattern who are suffering from nasobronchial allergy. And we had shown the mean cumulative dose for the inhalational corticosteroid and intranasal corticosteroid statistically significantly reduced after 12 months of initiation of allergen immunotherapy. And the cumulative medication score was also reduced with 12 months of therapy. So to summarize, again, when we talk about allergen immunotherapy, the history taking is very important. And yes, there is a role of clinical examination, SPT, the skin prick test, but we should not treat the skin prick test result, because skin prick test will only tell us about the sensitization status. We need to again retake the history. Second history is important, and after that second history, these are the important points, because this should be done with a shared decision making, and we should take a proper consent. Major allergen should be selected, so allergen selection should be proper. The counseling, especially the information related to delayed perceivable effectiveness, because many patients will think that today I am taking allergen therapy, so from tomorrow my inhaler will be so the information properly spread, and patient, this is a long-term relationship of 3 to 5 years, then only they will continue the allergen immunotherapy, so the compliance will be good. So we need to tell about the delayed effectiveness, perceivable effectiveness. So again, to summarize, what is allergen immunotherapy? This is the only option we have today that can target the master cells behind the allergy milieu. We know the masters behind that this allergy milieu is the T cell, and allergen immunotherapy is the only option we have that target the T cell and it modify the disease. We should have a proper patient selection. Again, we need to re-emphasize the importance of history taking, then skin prick test, and after that the second history taking. The allergen selection should be proper. We had discussed about the importance of standardization. Then there will be a building up period and maintenance phase, and safety assessment is always important, though they are, unless they are very safe, we can say from our experience. We should be prepared to manage them. How we should tackle anaphylaxis, that is also an important knowledge we should have. And after taking SCIT, the patient should be observed for 30 minutes. So that is also very important, because whether the patient is developing anaphylaxis or not need to be checked. So thank you once again. And again, very recently we had published our book that is on allergy, basic foundation of allergy practice, published during the Epicon 2025. If you are interested, it is available from the JP side. So thank you once again. I again want to thank my mentor, Professor Shoibal Moitra. Thank you.
Professor Sushant and session is Mr. Dr. Shantabam.
এটা বের করে দাও তো।
পিপিটিটা এখানে দেওয়া যাবে না? পিপিটিটা দেওয়া যাবে না?
কোথায় দেওয়া যাবে?
পেন ড্রাইভে ওখান থেকে।
পেন ড্রাইভ আছে?
হ্যাঁ পেন ড্রাইভ আছে।
দাও।
আসছে না সেজন্য আমি কপি করে
So may I invite Mr. Shondeep Goswami, and Shondeep Goswami needs no introduction. Instead of due to some issues, we miss our director, Dr. Arijit Dash, but Mr. Shondeep Goswami will tell us that how to build one allergy setup inside in our country, and how we can have some service that can be provided to our patients who are suffering from allergy. And we know that 30% of our population is suffering from allergy. We need to take care of them. And we are really privileged to have with us Professor Shushanto Bandopadhyay. Professor Shushanto Bandopadhyay was Director of Medical Education of Government of West Bengal, and he had served a long time, I think record time, as Director of Medical Education for Government of West Bengal and ex officio secretary. So may I invite Professor Shushanto Bandopadhyay sir to have some notes on from your huge experience, also tell us, and then we'll proceed for the presentation.
Good afternoon, everybody. Thank you, Shambho, for your introduction. So actually, we are having this conference basically on allergy and treatment of asthma, basically. So naturally, we are expecting to having a good discussion on these issues. So without wasting any time, I will request Mr. Sandeep Goswami to carry on with your deliberation, and after that we can have some discussion on your issues. Thank you.
Good afternoon, delegates. Good afternoon, sir. It is my privilege to give knowledge and experience to build up the allergy center and with the latest technologies and the devices to diagnose different allergies, patients, diagnose the condition of the lungs, in nutshell, as a whole, the management of allergy and asthma, and in Eastern India through allergy asthma treatment. Almost 40 years back, we started in Kolkata through Professor Sachin Chaudhary, who is a renowned immunologist from USA, along with Brigadier Dr. Nirendra Chandra Das. Both of them started in South Calcutta, and then Dr. Arijit Das, son of late Brigadier Dr. Nirendra Chandra Das, developed this center with his new innovations and continuous efforts. Countries like Bangladesh, the neighboring states like Jharkhand, Bihar, Orissa, and other places. Ready? Basically, just sorry for delay due to some technical problems. Basically, how to start? We have started options of all sorts of tests. Initially, when the patient comes, the atopic, particularly the allergic rhinitis or allergic mild to moderate asthma, or atopic dermatitis, urticaria, eczema. In all those cases, what do you need to do? We go for the allergy test. All the doctors take allergy test. And we have, in our organization, we have the facilities to provide to the patients both in vitro and in vivo. That means through blood test as well as through skin prick test. We have almost 120 allergens for skin prick test, indigenous, all are indigenous allergens. We do the test, we have panel wise, like panel, dust panel, mite panel, dander panel, and uh, 64 A's that we take it from Korea, and so one is immunoblot and one is ELISA method. So these are the two methods. Other than that, I'm going into the slides. That I have already told that in vivo, in vitro both. Allergy skin prick test, we have mites and dust panel, almost 10 allergens. We have the animal dander panel, 5 allergens, molds panel, 10 allergens, pollen panel, 23 allergens, insect panels, 7 allergens, veg food panel, 30 allergens, non-veg food panel, 10 allergens. Where? Next, we have started the ASST, autologous serum skin test, in vivo clinical test for the detection of what we do. We take the blood sample, we go for the serum, and then with the serum we do the test. We have started already for the, particularly for the chronic spontaneous urticaria patients. We have the drug allergy test. It is more authentic through skin prick test compared to blood test. We have the all sorts of drugs as per the prescription of the doctors who are prescribing for any particular drug, or maybe the panel wise we do the drug allergy test. In vitro test, we have the allergy profile test. As I told you that the total IgE test is there. Then it's do the specific IgE for the ELISA method, that is the quantitative measurement. Immunoblot method, that both quantitative and qualitative measurement, that is protea, allergy Q, total IgE, aspergillus IgG, IgM and IgE there. Quantitative measurement through ELISA method, which we do. That is pulmonology to the patients of suffering from something like that. Eosinophilic cationic protein is levels, and share is important to diagnose a variety of allergic disorders, both for allergic and asthma. Food intolerances, this is very, very important. It's not IG, not the allergy test, specific IG test. Food intolerance test is very important. Because many people who come, they cannot understand what is the problem. Suffering from bloating, indigestion, headache, sometimes types of situation. These are the things medicine you take so many and other things. That due to the food intolerance, some of the foods absolutely intolerant to the body of that particular patient. And if you stop it, we can identify it. It may be lentil, it may be rice, it may be wheat, it may be mutton, it may be anything. If we can identify and stop that absolutely, then there is no question of facing those sort of problems in future. It has been identified through the food intolerance test. We have the IgG4 test. This is not specific IgG4. We have the specific, but that is very costly. We do the IgG4 test. Particularly those who are under the as of the immunotherapy vaccines. We have the pathology, biochemistry, and microbiology. All sorts of blood tests, complete blood count, urea, creatinine, uric acid, everything, vitamin D3, and total diabetes panel, metabolic health panel, obesity, renal panel, liver health panel, bone health panel, anemic panel, thyroid panel, all sorts of lipid profile. These are common. These are very common in all laboratories. Basic. Now coming, it's very important, is the pulmonary function tests. This PFT, what is the spirometry? That is the PFT which we have. We have this spirometry test done in all the branches. By the way, I must share with you, it is my proud privilege to share this experience that we had two branches earlier in Moulali and Gorihat Golpark area. Recently, we have opened the third branch in Lake Town, just behind that Big Ben clock tower. That is our all the branches, the allergy tests and lung function test, everything is available. Then carbon dioxide, then lung function volume test. We do not have the body box now, but in future we have the plan to bring this body box. We have BPT, bronchial propagation or bronchial challenge test. We have the fractional excel nitric oxide FeNO that we launched in Eastern India first in the year 2017. First time in Eastern India. We have the oscillometric tests. Oscillometry, the testing measures blockers to airflow in the lungs. And it's used to check lung function or pulmonary function in very young children and other people who had difficulty following directions or breathing deeply. The test is done by having your child breathe normally through a tube connected to a computer. But there are two types of oscillometric tests. One is forced oscillation technique, that is FOT, and another one is the impulse oscillometry. We have both the facilities, both FOT as well as IOS. The main difference between impulse and forced oscillometry is that in FOT, the sound waves of different frequencies were transmitted sequentially, whereas in IOS, an impulse which can be mathematically decomposed into different frequencies is transmitted. This helps in reducing the time of test and also provides a high signal to noise resolution. This is the way we got the best award from this TV9 channel, TV9 Bangla, as the excellence in allergy and immunology in Eastern India, last year and this year also. Music. Music. Dr. Dash, who is our executive chairman and who basically popularized this allergy treatment almost 25-30 years back. Thank you. Any question? This is the services we are providing, and basically the transformative initiative by Allergy Asthma Treatment Center. Dr. Dash, our executive chairman, because of certain important meeting, he had to go to other place. That's why he couldn't be able to attend this program. But he has already sent his message to make it grand success. And this is my humble request to think about Allergy Asthma Treatment Center for any assistance regarding allergy test, regarding allergy related any test, regarding lung function test or immunotherapy, anything. Our doctors are there, our technicians, well-trained technicians are there. They are always ready to help you out. Thank you.
So, thank you, Mr. Goswami, for your nice presentation about this allergy detection and lung function and others which you do. Do you have any question from the audience? Otherwise, I would like to ask you one question.
Yes, sir.
The question is that now the actually two questions actually I have. One is what about the cost of these tests? I mean, is it quite friendly or it is very expensive? This is one.
Sir, the thing is, it varies test to test, number one. It is, I cannot say very cheap, but I cannot say very costly. It's moderate. It depends upon some of the kits which are buying from outside. Because the kits are coming from abroad. It varies a little bit depending upon the dollar fluctuation. So we have to keep it because the foreign companies which they charge based on the dollar fluctuation. So we have to keep it in a moderately, not very cheap, not very costly. But if you compare with some of the tests, all the tests are not available under one roof in Eastern India, nowhere. But if you part by part, if you compare between A and B and with us, then you will see that it is definitely cheaper than those places.
Another question I do have, after detecting the allergens, pollens or whatever you detect by your process, what are the procedures you find out about the management of the these allergens, so that the patient, is it curable? Is it possible? Besides our management, bronchial asthma management and that's a different issue. But I'm asking is, have you got any specific this thing for management of these cases?
Yeah, basically if you identify, the first thing is for the atopic cases, first thing is to identify the allergen. Which allergens are causing this sort of allergic disorders. If we identify the allergies, I may request Dr. Shambhu to come on the stage to address this. Then we treat those allergens with the immunotherapy, other than the regular medicines. And immunotherapy is based on the allergens only. It is allergen immunotherapy, AIT.
Yeah, so may I have some comment?
Yeah.
So actually what we do in our center, Allergy Asthma Treatment Center, one part is diagnostic But again, when we talk about diagnostic, one of the very important issue is history taking. So there is a dedicated chamber of history taking for all the patients who attend our clinic. So after history taking, we plan for certain tests. The basic tests are skin prick test and some of the lung function test. Sometimes it is spirometry, sometimes it is pheno, and in some subset we may need to do some DLCO also. The thing is that after the detection, what you had asked, what we are giving extra to our patient, that is the allergen immunotherapy we are providing. The allergen specific immunotherapy we are giving here, the subcutaneous immunotherapy, depending on the skin prick test report and the history and the other issues. The allergen immunotherapy from our center provided towards our patient, subcutaneous immunotherapy, and that word is very crucial, that cure word. As you also had asked, this is the information we need to spread towards patient, because there is in one of our presentation today only we had talked about the compliance to the allergen immunotherapy. So if someone have this in his mind that I will be cured by allergen immunotherapy, then it is a false or we can say misconception. Nothing is cured in our dictionary, medical dictionary, except certain infections, certain cancers also we can say, yes, cure terminology. About another C word, that is control.
Control.
Our target is to control your disease. Our target is to improve the patient. So this word, again, the cure word, we never use, and we are going to give you a treatment for 3 to 5 years. That also need to be told. This is a long-term treatment. It is not for a 1 shot, 2 shot, or 1 year treatment. It is a 3 to 5 years treatment. That also we need to tell to our patient. And on another issue is that we should not give any false message that all your medications, all your inhalers will going to be stopped. So the pharmacotherapy, they had a huge role, immense role, and on top of that, we are providing something which is going to modulate your immune response and going to give you the improvement in terms of quality of life, and your medication score will go down with subsequently. So I think this is one of our approach. I think we have with us today from Chennai Apollo, Dr. Karthik Nagarazu, who is a very famous pulmonologist there and allergist also. So may I request your take on this? What you also do in your, how you talk with your patient, and what is your approach?
Thank you, sir. So similar things to what you said. I mean, amazing suggestions and points. Similar thing when we talk about allergen immunotherapy, again, like how we said, it is an immune modulating disease. Like how we have autoimmune diseases where there is a disease control, we also explain to the patients that we are trying to control your immune system and train them to tolerate the allergen and not try to treat it as a disease. We tell them that we train your immune system to treat it as a non-infectious and harmless substance. So based on this training requires certain time period, and that is why we say that the duration of treatment is somewhere between 2.5 to 3 years minimum, sometimes even up to 5 years. So with this background, we explain to them that because your immune system has already undergone a lot of training, as an adult, it may take you longer to respond. And if you're a child with your immune system being in the immature phase or in a growing phase, you may be able to train it better. So these are some of the tools that we use for feedback also. Other tools that we use is that their lung function testing, how many times they're getting admitted. We also explain to them that the cost of treatment for admissions and further treatment with nebulizations and injections, they are all coming down over time. So the immediate cost that you tend to see with allergen immunotherapy actually provides long-term benefit with reduction in these admissions, exacerbations, injectable uses, and side effects, and further medication uses are coming down. So the overall benefit is also not just risk benefit but also cost benefit. So with all this put together and using certain feedback tools like lung function and their skin test reaction, how big the size of reaction is, and after treatment how much the size of reaction has come down also, these are good feedback tools that we use to explain, look, you were so severely sensitive earlier, now your sensitivity has come down, so this is how we are improving over time. So these are certain ways in which we counsel them and explain and use as tools for allergen immunotherapy, in addition to what you were suggesting.
Thank you, Dr. Nagaraju, because last word you had mentioned about the cost effectiveness. I think this is again a very important message. In US, the SLEET, the sublingual immunotherapy, the cost is very high compared to our country. Even the SCEAT is very costly, but compared to our country. But they had done the cost effectiveness studies, and they had those are very well controlled pharmacoeconomic studies, and the cost effectiveness ratio was clearly in favoring the allergen immunotherapy. So that is one again another avenue why we should tell our patient, yes, if you were allergic, if you are the right patient, you will definitely this therapy will give you cost effectiveness in future. So I think that is again another important point.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Shambhu. Thank you, Dr. Nagaraju.
So,
thank you, sir.
We had a very good discussion on these issues, and thank you, Mr. Goswami, for giving such a nice deliberation.
Probably we have given you the answer through Dr. Shambhu and Dr. Nagaraju.
Okay.
Thank you, sir. Thank you very much.
Thank you.
Now may I request Professor Shushanto Bandhopadhyay sir to please come in front, and Mr. Sandeep Goswami. I think we have now 1 hour lunch break. So there is the arrangement for lunch is there. I am requesting you all to have a good lunch. Then we'll come back. I think we'll again restart the scientific session from 2:30. Yeah, 2:30. Okay. So purposefully we make some time for that peer connect also. So if we have some more discussion, so please have the lunch there, and we can have some peer connect, and we'll start the scientific session from 2:30 p.m. Thank you.